Welcome to our current version of the Thyroid Multidisciplinary Seminar Series. This morning we have three very interesting cases for us to talk about with our panel over the course of the next hour or so. Okay, next slide. We'll do our usual thing and have our panelists introduce themselves. I'm Mike Tuttle. I'm one of the endocrinologists at Memorial Sloan Kettering Cancer Center, and apparently my full-time job these days is running tumor boards. That's what I do these days. Let's start from Camilo up at the top.
Hi everyone. My name is Camilo Gonzalez Velazquez. I am an endocrinologist in Universidad Autónoma de Nuevo León in Monterrey, Mexico.
Dr. Sugitani.
Hello, my name is Iwao Sugitani from Tokyo. I'm a thyroid surgeon from the Department of Endocrine Surgery, Nippon Medical School.
Fantastic. Welcome, Iwao. Dr. Khorsandi.
Azita Khorsandi, radiologist, Mount Sinai, New York.
And our infamous pathologist, Dr. Brandwein-Weber.
Notorious, Margie Brandwein-Weber. I'm the chief of pathology at Mount Sinai West. I'm a head and neck pathologist, and I work with Mark Erkin.
You poor thing. Dr. Worden.
Hi, Frank Worden, medical oncology at University of Michigan Rogel Cancer Center.
Fantastic. And David.
David Pattison, nuclear medicine specialist, director of nuclear medicine at the Royal Brisbane and Women's Hospital.
Fantastic. Well, our cases today are coming from the Mayo Clinic, so I'll ask Dr. Brito to introduce himself and also to introduce Dr. Toro Tobon.
Thank you, Mike. I'm JP Brito, endocrinologist at Mayo Clinic, and happy to be here. I'm here with David Toro Tobon. And David is a physician from Colombia, trained in endocrinology with us in Mayo Clinic, and now he's my colleague in the Thyroid Clinic. So we are happy to present the three cases for you. And I will be presenting the first one, and then David will be presenting the second one and the third one.
Perfect. Okay, so let's go ahead and look at the first case.
Okay.
Perfect. Looks good.
Yeah. So the first case is somebody that was treated mostly in a different institution, but we at the end of the process we ended up seeing this patient. So he's a 57 years old male that has the Wirt-Haupt-Dubé syndrome, and of course I had no idea about this syndrome, so I had to read it. But this is how he presented with a rhabdomyoma of his tongue many years ago. And it was resected and then recurred and was resected again. Had several CAT scans over the years, and one of the CAT scans actually found a nodule in the left thyroid lobe that was incidentally noted in one of those scans. They also noted a couple of lymph nodes in the left neck. They did a biopsy of the nodule on the left thyroid lobe. It was a 2-centimeter one. It was suspicious for hortocell neoplasia, and also a lymph node biopsy of the left neck was also suspicious for hortocells. So they performed a total thyroidectomy and a left neck dissection. So we do have the slides of that pathology.
Margie, this is always unfair.
Sure.
Can you squint and give us any idea here?
Well, as squint and wave an imaginary ruler, right? So what you can see here are just nodules. You can see darker nodules, and then sort of lighter nodules and there's blood and there's pink stuff, And so, generally from this altitude, you really can't say anything. But knowing that we're dealing with an oncocytic lesion, you can imagine that these sort of bluish nodules actually represent invasion of carcinoma. Okay, next. Okay, so here again, it's not really high power. What we do see as a predominant background is a kind of pink-purple cytoplasm, and that supports the diagnosis of a Hürthle cell neoplasia. Now, if you can look into the nuclei, you could see that they're round with a prominent nucleoli. And again, that's not PTC, so that supports a Hürthle cell neoplasia. So what I see, I couldn't make the diagnosis of Hürthle cell carcinoma, but it's certainly all consistent with a Hürthle cell carcinoma. So apparently there was also vascular invasion, which is very important in this story.
Okay, David?
Yeah, that's exactly what it was found. It was a 2-centimeter, it was a high-grade oncocytic carcinoma, it was wildly invasive with extensive angio lymphatic invasion as well. There was no extrathyroidal extension. The surgical resection margins were negative for tumors. There were at least 10 lymph nodes that were positive for metastatic involvement, mostly in the central compartment, level 3 and level 4. as we expected, at least from what the preoperative ultrasound and biopsy was showing us.
Yeah. Margie, let me come back to you for just a second here, because this new terminology from the latest WHO,
Exactly.
help me structure what this is, Margie.
This makes sense. Right. So, my eye jumped to a differentiated high grade. And so I'm hoping that they use it in the regular, in the now the accepted term. So differentiated high grade basically replaces the term undifferentiated, which was a fine term. It went to signify a number of different kinds of tumors. The advantage of just changing the terminology, saying differentiated high grade, is that it really represents sort of a diagnostic overlay on everything, which has a lot of significant impact. So it's kind of a uniformity. And the diagnostic overlay is this: necrosis and or mitotic, higher mitotic activity. So one or the other will knock a tumor out of the category of low grade thyroid cancer. So low grade thyroid, or well differentiated thyroid cancer. So well differentiated thyroid cancer is a whole spectrum from PTC, from good to bad, follicular and Hürthle cell carcinoma from good to bad. Now, when you have necrosis and or a significant mitotic rate over 5 per, and I think it's a millimeter squared, but don't quote me. I always have to go back and look at the data. Then you take it out of the ATA-ROR, you take it out of the classification of well-differentiated thyroid carcinoma, and you put it into this classification, which is differentiated high grade. Differentiated to distinguish it from anaplastic.
Yeah, in this case, mitotic rate was high and there was presence of necrosis.
There you go.
And so, Camilo, how are you thinking about this case now? I mean, this is not papillary. There's a lot of bad words in this thing. So how are you thinking about this one, Camilo?
So first of all, I would be asking around, like JP was mentioning, about the if the syndrome changed in any way the diagnosis that I'm getting. It is not a common animal. It's not a common run-in-the-mill lesion. So I would be thinking of classifying this as a higher risk of recurrence and trying to give this patient a higher dose of radioactive iodine if that was possible.
Okay, so we'll come back through this. Yeah, and I think without diving too much in the syndrome, anytime you have somebody with one of these familial syndromes, you always go back and look and see what the mutation is, right? And could that in any way sort of play into the thyroid cancer story that we're seeing, not just this one, but any one that we have here. And JP, just take care of that for me. Anything in this particular syndrome that would play into our thyroid cancer story?
It might. In fact, there is a new paper in Thyroid about the syndrome with 5 cases of thyroid cancer. They mostly associated with papillary, yet this is a tumor, this is a syndrome that is associated with a folliculin mutation, this particular protein that has to be with the mitochondrial energy change of things. And we know that Hürthle cells have to do with mitochondrial stuff. In fact, the tumor presents with kidney tumor as well, benign and malignant. And the cells in the kidney tumor tend to be Hürthle-like. I know that it's not always the same, but they tend to be Hürthle-like. So it's an interesting association of things there. But Hürthle cell with this tumor is not described in the literature.
Okay, so let's keep going through the case.
So the team waited without levothyroxine, I think going with Camilo's thought they wanted to give radioactive iodine. And this is the scan that you're seeing there, only uptake in the neck. They describe as 2 iodine-avid left-sided cervical areas, probably mostly although they say left, but it's mostly in the central compartment, 6 and 7, so lower part. They also mentioned something in the lung, but without any iodine uptake. So they thought that would be good reason enough to move forward with radioactive iodine, and patient received 150 millicuries. As you can see also in the table, the 137, of course, was the stimulated thyroglobulin. It was 5.1 at that time.
David, David, give me a feel for RAI avidity in this tumor, FDG avidity. How are you sort of thinking about this tumor now, David?
Yeah, certainly. So it's a high risk of recurrence, oncocytic carcinoma. that's widely invasive. Typically, we can see some radioactive iodine uptake, but it's not typically intensely iodine avid. They don't typically respond that well. Sometimes you're not avid at all. And with regard to FDG avidity, as mentioned before, there is this oncocytic phenotype, and it's due to a defect in the oxidative respiratory chain of the mitochondria. It's very inefficient in its metabolism, and that means it uses a lot of glycolytic metabolism and uses a lot of FDG. And so it means that whenever we see oncocytic tumors, which can be thyroid, they can be in the parotid as Wartham's tumors or renal oncocytoma, they're always characteristically very FDG avid, and that's whether they're benign or malignant. So even benign Hürthle cell adenoma is a common cause of incidental thyroid nodules. And so the way we're thinking is, we typically treat them the same way, and we'll treat them with radioactive iodine, but not necessarily expecting a lot of uptake. And so one of the things, when I look at these images of the planar images of the, neck and chest, I just wonder if there was a SPECT CT just to make sure that that was definitely nodal uptake, because to my eye, it looks very similar. It looks like thyroglossal tract uptake in the midline, and then possibly, just be interesting to correlate. But because it's very intensely avid, it looks more akin to thyroid remnant uptake. But there may have been a SPECT CT that's confirmed that.
Yeah, very good. And I think that's part of the confusion on these is whether they're RAI avid or not. We have really swung away from doing radioactive iodine in these oncocytic ones, but still many even in our group would give at least one dose up front to see what happened. So maybe some uptake, maybe not. All right, JP, keep going.
All right. So the patient received that, and then the thyroglobulin, as you can see, did not really decrease that much, from 5.1 to 4.5, and then start increasing again, 6.2, 10.5, 14, and 26. So at that time, the team decided to go again with an uptake scan, and this time on the left panel, they didn't see anything. They moved forward with a PET scan, and yes, I'm not sure you want me to describe, but there is a lesion there in the midline, a small one. PET avid, and we do have the ultrasound there that we can run the video that has that nodule there.
And where is that? That's thyroid bed, midline level 6, or do we know where that is?
Yes, midline level 6.
All right. Dr. Sugitani?
Yes.
We're headed toward a surgical thing. This is having to reoperate on somebody. This is 7 months from their surgery, and we've got something regrowing, presumably where you just operated. What would this surgery look like if you had to do a surgery here, Iwao?
It's a place that usually the intact for the former surgery, so we can pretty easily to resect this tumor. But
yes.
Yeah, probably.
So resectable. Camilo, that thyroid, we're 7 months, and we've gone from 5 to 26. What are you thinking there?
I'm thinking we have not only a recurrence, but a bad behaving tumor. I was wondering, and if I may, David was mentioning the possibility of doing an FDG uptake scan, and we know that oncocytic and these type of tumors might not uptake radioactive iodine well, but let's think about the less fortunate bunch of us, people that are not in places where we can do simultaneously 2 scans at once. David, would you push towards doing an FDG from the get-go, from the beginning, so you have a better sense of where the disease is and then treat it upfront differently? And if you would, I would want to ask the panel, how would you treat this differently prior to going for a radioactive iodine scan or treatment 10 scan?
Yeah, I mean, look, it's a good question. And one of the aspects about, molecular imaging or nuclear medicine or all scans is that there can be variable access around the world and for different reasons and different costs. And in Australia, for example, FDG PET scans are not particularly expensive. They're just a little bit more expensive than CT scans. So we may use them more commonly than some other sites. And I think you could make a case for that, just on clinical grounds. It's likely to be FDG avid. Depends what the thyroglobulin is. I mean, our standard indication is, with that raised thyroglobulin, typically certainly above 10 or at that level if it's stimulated, or if it's not, particularly if it's not radioiodine avid. So, I mean, we may well use that earlier, but I mean, typically our standard approach would still be to do the radioactive iodine first and then, follow up after that.
So
Okay.
let me follow up with Azita. Azita, because even I have patients that the insurance doesn't work for FDG PET scan. They've had their surgery done outside. In this exact case, a lot of times I want to do either a CT scan of the neck and chest with contrast or ultrasound imaging. Sometimes we're only 2 or 3 months after the surgery. Can you interpret what's in the neck when I do it that early, or am I just wasting money?
3 months, yes. So if you have 3 months, if you have a good ultrasonographer, you can look at the central compartment, relatively, hopefully the patient doesn't have a short neck and you have a good sonographer. You can look at the central compartment, look at the lateral compartment. And again, we've had this discussion, you will miss the lateral retropharyngeal lymph nodes. The easiest thing is if, again, you need to have someone who does this a lot, a radiologist, if you get a CT of a neck, that may just pick up what you need.
Okay. All right,
And
JP.
it could be a substitute for, I'm sorry to interrupt, for the PET CT if you can't afford it.
Yeah. So on this one, I would have definitely wanted to look at the chest as a minimum up front on one like this with that vascular invasion, oncocytic, knowing I wasn't going to trust the thyroglobulin. Now, the thyroglobulin was only 5, and these tend to be good thyroglobulin producers. So you could make the argument, Camilla, you were going to wait for 3 to 6 months. So I think that's in a reasonable recommendation.
Yeah, correct. That's where I was gonna go after. When I think of cases like this, I always think of that algorithm that is in the ESMO guidelines, where you have a patient that is either symptomatic or asymptomatic, progressive or not progressive. So I wanna see how this behaves. And although the thyroglobulin is not behaving well, so I'll go back to that podcast that you recorded with the rising thyroglobulin, and I'm trying to watch and wait. And I'm not sure that this small nodule is gonna be the producer of the entirety of this level of thyroglobulin. So watch, wait, and move.
Agree, Camilla. You can count on one hand the number of people I've seen have a thyroglobulin go from 5 to 26 in 7 months, right? This is a big red flag. I doubt that that's the only source of disease. I'm worried there's a bone met somewhere. So this is a worrisome. All right, JP, keep us going through the story.
All right. So next slide, please, David. So yes, surgery was done. There was a pre-caicot tissue was described as a recurrent hortocell carcinoma. Exactly what was removed in regards to whether it was soft tissue, lymph node, it was not really clear in the report, but this is what the surgery that went through. We don't have pathology for this one.
Yeah, and unfortunately, that's really an important point, right? Whether this is a lymph node, these oncocytics love to recur in the soft tissue, and when they do, they keep recurring in the soft tissue. And Margie, if we just give you a slide, can you tell the difference there?
It depends, right? Like with everything. Mark and I had one case a number of years ago where there was like sort of benign rounded things, in the soft tissue, and it was in the bed, and so. It really did not stand on its own as cancer. Same patient in the future, once these things become very irregularly shaped, once they're away from the soft tissue, even if they look, as bland as anything and round, then you could say it's metastasis, but, can be very difficult.
Gotcha. Okay, JP, go ahead.
So the postoperative thyroglobulin did not change that much, just a couple of months after the surgery. They was 30.5, so that team decided to go on and around another PET scan, trying to find maybe what the group has been describing as something else going on. They noticed, as you can see, maybe postoperative changes in midline, but there were at least this lesion in the left neck, and maybe bilateral supraclavicular one, and at least the one in the left is clear to be seen. So they thought that there was something else going on there.
All right. Then go ahead.
Oh.
So they did, again, in a very short period of time, a third surgery. This is the left neck revision, and you can see the slides there.
Right. And so, now that we know it was already had necrosis and a higher mitotic rate from the initial diagnosis, we're not worried about grade progression because grade progression has already happened. I don't think I've ever seen any of these actually progress to an anaplastic, although that's always a possibility. But, right, tissue ain't supposed to be, that's malignant.
Perfect. And then we have the pathology, so it's still characterized as lymph nodes with poorly differentiated oncocytic carcinoma, mostly in level 4. And there was extranodal extension. As you can see there, there is a surgical node I think is quite relevant just to express how difficult probably that resection was from the surgical perspective. Very fixed, firm lymph nodes, and they had to actually sacrifice the sympathetic trunk. I think that was a signal that there might be some tissue left there.
Dr. Sugitani, any comments on the surgery here?
Yeah, at this point, we feel that this disease cannot be controlled by surgery only, but it depends on the very rare syndrome, so we can think of many things.
Right. But we're starting to get to the point where this is not going to be a surgical issue, right? It's coming back over and over. Frank, should I be thinking about external beam radiation here? Do you have something to offer from the systemic? This poor guy's been to surgery, 3 times over the first year or something?
Yeah. So anything that is local and symptomatic, I probably would consult my radiation oncologist to see if there is room for radiation. I mean, I'm getting to the point where this patient's going to need systemic therapy, but if we can buy a little time with radiation, I think I'd start there.
So, Frank, a lot of times this new discussion has come up where this patient is going to have distant mets. That's going to be his story, right? Over the course of the next few years, he's probably going to need a systemic therapy, unlikely to have a targetable mutation, right? Because he's oncocytic. So this whole discussion of, if I do external beam radiation now, do I have complications from the TKIs and the VEGF inhibitors? Can you talk a little bit how you're thinking about that, Frank?
Yeah, I mean, those with tracheal invasion, or esophageal invasion, we worry about, the formation of fistulas with radiation. Now, it's interesting, and I had a discussion with my radiation oncologist recently about this, and it really kind of depends on, the location, the size, and the dose, the radiation. So if there's not a large amount of radiation given, they give 4 fractions or so, just for control of disease, because I know we're going to follow up with systemic therapy. It probably it's not going to be a problem. But if the disease is so much more extensive and you're going to give a bigger dose and a longer dose of radiation, certainly we have to worry about that on the back end when we give tyrosine kinase inhibitors. Yeah.
That's often, we find in these situations, it's really important to have both the radiation oncologist and the medical oncologist involved in that first radiation decision. And frankly, I didn't used to always do that, right? That was just a surgery, radiation oncology. But now understanding what's going to happen down the stream is important. Okay,
Absolutely.
JP, keep me going, and let's finish this one up.
Yeah, let's move forward. So then 18 months after the initial diagnosis, which is only a few months after the third revision, thyroid globally now is 226. Again, all of them in suppressed TSH. And then we saw the patient, and you can move forward a bit, please. And then we did a PET scan, and again, perhaps as expected, there is something in the left neck, but it's not that much tissue as we thought it will be. So that's the couple of lesions, was the same lesion, but in reality, there are a couple of sub-centimeter or around centimeter lesions in the left neck. We requested genetic testing of the tumor that was initially removed, and it was a PT53, and the mutation in the folliculin, that which part of the syndrome that we were describing at the beginning. Next. And at that point, we thought that we can monitor the disease because the patient also went through a lot already, and they wanted to see how this will evolve. And we continue close surveillance, and you can see there another PET, and now we're seeing a liver lesion in the MRI and the PET scan, as you can note it there. So that's, I think we knew that maybe something was coming, and the liver was the area. And when you have liver and when you have that, you think about bone too. So there is a T3 lesion as well, a metastatic area there. So at this point, the question to us, and actually to his home institution, is, so what next? Local versus systemic therapy.
So we've got some small volume disease in the neck, we've got small volume lung metastasis, and we've got the bone metastasis that all of us were expecting because of that dramatic rise in TG. That pattern of exponential rise over a year or so in the absence of big structural disease almost always heralds bone metastasis. So that's where we are. David, what are you thinking here now?
Which David? David Pattison?
Yeah, absolutely.
Yeah.
We'll drag
Yeah,
you
yeah.
in from down under.
Yeah, absolutely. Yeah, great. So, essentially, we didn't specify it earlier, but, this patient has got radioiodine refractory disease because there was no uptake on that iodine scan previously. And at this point, it's as we expected, high TG, small amount of disease in the neck consistently. And so we have found that those distant sites, at this point, I think you're really thinking about, we will need treatment. You're certainly thinking about symptoms and where those symptoms are. I think that lesion in T3 is concerning. It's probably painful. And so, and then weighing that up on the extent of the other sites in the neck, I think there's been another 6 to 12 months maybe since previously, and it still seems to be reasonably small volume. So I'm thinking potentially initially local therapy to the back, but it is dependent on symptoms, but I think systemic treatment is likely to be required, if not now, but imminently, because there are these multiple sites of disease.
Yeah, me too. So Frank, assume that we're going to radiate this spine met because it's growing and it's there and it's not structurally, doesn't need surgery. Just pretend with me, we radiate that. Time to start therapy now. When do you start? I mean, we ask this question every time, but it's a challenge.
Yeah. Well, the first thing I'd probably do is after radiation, consider bisphosphonate therapy, for this patient because of the bone disease. And then it's the discussion about, when do we start? Now, in this case, Margie has laid out the case quite nicely that this is an aggressive tumor. So this kind of person, it makes me more nervous. And depending on the symptomatology. So certainly if we can get by with treatment with radiation and the patient says, let me watch this, I wouldn't go any more than 3 months.
Yeah.
TSH suppression has to take place, and I think the patient's TSH here was suppressed. So, but let's say it pops up even more and systemic therapy is needed. Yes, if we do an NGS testing, we would be looking for a driver mutation, and Mike, you had said it well. It probably is RAS or have anything. It's interesting, these oncocytics in these high-grade oncocytics do kind of behave in a way like anaplastic, meaning that there could be a role for actually immunotherapy, which we wouldn't offer in patients who have differentiated thyroid cancers, at least up front, and those who haven't transformed. So I probably would ask my pathologist to start with, do we have a CPS score? We do know the higher CPS, the better. So if it came back as 1, it's probably something I wouldn't put in my toolbox. But even starting with that wouldn't be the treatment of choice. It would be something like a pan-tyrosine kinase inhibitor such as lenvatinib. So that's where I would start if we're going to start therapy in this particular patient.
Well, that sounds good. JP, finish this one up for me, and then let's move to the next one.
So with this one, it will be 3 tumor boards the patient went through, one in his local institution, one in our institution, and both we were leaning towards exactly what's happening here. Mostly, we might need to start a systemic therapy, but patient was very vocal about not wanting going to systemic therapy, concerns about medications, personal preferences. So we designed a plan of managing this condition with the warning that we are seeing fast progression, and for now we will control the disease as it comes, but pending perhaps systemic therapy. So a fourth surgery was done. This time, as you can see, we are still seeing deposits very well described of tumor, which is the red flag that we were discussing before. I think the surgery went very well. He had radiation to the bone lesion. We did MRI with the back, no more lesions other than that one. And the liver lesion was ablated. So we treated as before TKIs, but I think we know that this might progress in a way that we might need it.
Well, I think that's valuable. If the patient's value is to stay off systemic therapy for another 6 months, possibly a year, because you occasionally have another bone met you can treat. The lung mets go kind of slow, so this is not unreasonable. And then we've all had other people that wanted to start with Frank as soon as they had their second recurrence, right? They're wanting to rush a little bit earlier. Okay,
and we will complete with radiation of the neck as well to control the disease.
Yeah, that sounds good. Okay, that's a good case. All right, JP, you got a short middle one for me here.
Yeah,
or
and
David
will
who's
be
doing?
yes.
David.
Perfect. Yeah, so this one is actually shorter, but I think it's something that we commonly find in our day-to-day. So it's a 58-year-old male found to have a palpable thyroid nodule on routine clinical exam, asymptomatic. And this was a 4.4 centimeter right-sided nodule, and there was a 1.5 centimeter left-sided spongiform nodule. This is the video clip of the 4.4 centimeter right-sided nodule.
Azita, any high-level thoughts about this other than it looks like there's a storm front coming in from the west to me?
The ultrasound, my first thing, believe it or not, I look for extrathyroidal extension. Everybody else can see the lesion is echogenic, it's cystic, it's heterogeneous, it's wider than taller. But I think if you look at it at its interface with the trachea, at least from what I see, I don't see any invasion. I don't see any invasion through the strap muscle so there is no extrathyroidal extension. And after that, we have to do tissue sampling. The only thing I'll be cautious about is where you do your tissue sampling, which portion of this nodule.
Dr. Sugitani, in Japan, when you see this sort of 4.4 centimeter right-sided thyroid nodule, what's your usual evaluation?
Of course, ultrasound and fine needle aspiration, because we don't have a commercially available molecular testing, so that we are reluctant to perform surgery or every tumor over 4 centimeter, but the symptoms and our patient's preference is most variable determinant for surgery.
Awesome. Okay, David?
So we did FNA, and then cytology was ATP of undetermined significance.
Of course it was. Yep. And then you work at the Mayo Clinic, so we sent off 3 different molecular tests. Is that how it works up there?
So actually, this was this was actually done outside of the Mayo Clinic initially. But yes, someone actually did a firma, and this was what the firma resulted.
All right, suspicious, but we don't have a driver gene. All right, Camilo, what do we do with this?
So in most of Mexico, the behavior would be very similar to what Dr. Sugitani said. There's people that would even push and I'm gonna go to David, the rest of the thyroid gland is clear. Do we have any lymph nodes that we could see from the ultrasound?
There were no lymph nodes that were worrisome.
So yeah, based on preference, I would go at this point anywhere from a lobectomy to a 12 thyroidectomy.
Now, what if I tell you that the patient's asymptomatic?
And they don't want to do anything?
They don't want surgery if at all possible.
So this is an uncomfortable situation. Because you said suspicious, yet you didn't give me a gene variation, fusion, mutation. So if this was BRAF positive, I would still lean towards the same. If it was not, there's a big trend towards ablative techniques. But I don't know if this is, going back to Dr. Tuttle's wording, might not be the ideal case for that, but I could accept surveillance.
So JP, help me through the logic here. I mean, we see this all the time. Somebody does molecular testing and the patient doesn't want surgery anyway. Was this a good use of molecular testing, or if you had to... Go ahead.
So this is exactly the goal of the case. This is a benign looking tumor to begin with, and that should drive everything else in decision making. When you have an AUS, in reality, the AUS for different institutions has different thresholds of cancer, and the AUS might still not change significantly the risk of malignancy. Here in Mayo Clinic, it's about 10 to 15%, for instance. And within the AUS, you have the nuclear atypia, and you have the architectural atypia that sometimes doesn't get reported. But when you build the case here, you start with a benign-looking tumor that has an AUS, and it comes as suspicious it comes in affirmative as follicular neoplasia. So probably telling us to some extent that is likely an architectural level of atypia. And those ones, when you have a benign looking nodule and an architectural atypia, the majority of those tend to be benign, which goes against to the idea that 50% of these positive affirmations are cancer. So just to maybe trying to decompose the idea that if a firma is positive, we're 50% of malignancy, which is not always the case.
Perfect. And what else did you do to this young man, David? Or did somebody else on the outside do?
So this patient came to us, and then we decided, okay, then let's do a core biopsy. And this
Okay.
was the result of our core biopsy.
Margie, help me here with this logic, because we've got what, when we're down this AUS follicular neoplasia pathway, we're down a follicular neoplasm pathway, and you need to see the capsule to tell me whether it's cancer or not.
Right.
So
right.
how
this,
does, yeah.
This satisfies do something.
Yeah.
So something was done, and so a core needle biopsy is unless you're thinking about anaplastic, it's a low yield thing. So what can I tell you here, just based on the histology alone? It's not PTC in this core needle biopsy. So something was done.
Really? And
Yeah.
your report says something was done, Margie? You're going to charge for that?
I don't write. I don't write a fraction of the things I think.
That's probably good for both of us. That's
Yes.
very good. All right. So at least it told us it's not a papillary thyroid cancer.
Right.
Probably not a follicular variant of papillary as well, right, Margie?
Exactly.
Right. So it's
So
yeah.
NIFT-P is off the table. Now, certainly, I just want to point out that the lack of thyroglobulin here is kind of unusual, and it may correlate with the fact that this is thought to be spongiform.
Perfect. All right. So Camilo, at bottom line, what are you going to do for this gentleman?
So we see a lot of patients that come get you get the workup done or you get treated and then they never come back. Mexico is like that. So with that in mind, I would still push at least for a lobectomy. And you're putting me in a hot spot here, but if this was a patient that was very educated and was very thorough with this workup and follow up, I would definitely lean towards a more conservative approach, and David is, I think, hinting towards that when he was asking his question, and I do love that, but still there's a problem that needs to be solved, and I don't see this disappearing in any way. So if we wanted to go to an ablative technique, this is a gray zone. So still, I'm gonna say watch and wait. There's a lot of things in these partially cystic solid nodules that will change in the ATA guidelines. So I'm not sure if I wanna follow my heart and just watch this patient or do something really conservative here in Mexico, at least.
Yeah, I agree. I get to see a lot of these folks. Obviously, they come to see us because they don't want surgery, right? They're seeking out a very minimalistic management. And so I've become very comfortable following exactly the logic that JP outlined. I probably wouldn't have biopsied this to begin with, and I certainly wouldn't have done the molecular testing on it. So in patients that can understand that this could be a follicular thyroid cancer, it could be one with some vascular invasion that I can't tell about, but I think that's pretty low. And if they're comfortable following that with me, I'll follow along with them. And so what did you guys decide to do?
That is exactly what we're doing with this particular patient. So we're doing active surveillance with him.
Yeah. So, I mean, it's a risk benefit. It's a value preference of the patient, right? So what I personally would do might be different than what the patient would do. So as long as they understand what those risks and benefits are, then I try to respect their things. And at least in our situation, if I tell them it's okay to do that, a lot of times they will come back in 2 or 3 years and not just be completely lost to follow up. So great case, JP. All right, let's do one more.
Perfect. So this last case, it's a bit of a challenge because it's a 20 years case. It spans 20 years. So I'm going to try to guide you through it and the most important parts of it. And I do have some pointers in the questions, but of course I let Dr. Tuttle guide the discussion. It's a 42-year-old female that was diagnosed with a 1.5 centimeter follicular thyroid cancer with capsular and vascular invasion, T1B and 0M0. This patient underwent right lobectomy followed by completion thyroidectomy, and at the beginning, 20 years ago, had 2 doses of radioactive iodine, 158 and 182 millicurie, due to incomplete biochemical response. This was just during the first 2 years of diagnosis, very close to the initial surgery. It appears that after these 2 doses, this patient achieved complete structural and biochemical response. So I guess my first 2 pointers here were, how concerned are we about these patients?
Let me start with Margie to begin with. Margie, you took us through the oncocytic sort of classification. Take us through this follicular one.
Well, 20 years ago, the reports looked very different. And so vascular invasion, but we don't know if it's extensive, if it's, just one focus. So really, and then of course we don't know, is there necrosis? Unlikely in something that's so small, right? But, we're really limited by not knowing in this particular case, the extent of the vascular invasion.
Yep. Camilo, what do you did I lose you, Camilo? Do I still have you on there? We may have lost a little bit. Yeah, so I agree. I mean, 1.5 centimeter follicular thyroid cancers usually do very well. So the fact that this is showing up on a tumor board worries me a little bit. Camilo, thoughts about this 1.5 centimeter follicular thyroid cancer?
So this happens a whole lot here as well. So I'm not really worried, but there's some worry to an extent to those of radioactive iodine. Not sure what the scans were, and I would love to at least get a biochemical picture of what's happening. So I would tend to at least get thyroglobulin antibodies, see how worried I should be, and then choose my imaging modality based on what I see. I'm not so worried. It's been so long that if something were to progress in this time span, I would have the tendency to think that the patient would have some type of symptom or a reason to come in. But I'm thinking that something happened in between that will definitely drive us to be a little bit more aggressive.
David Pattison, help me. RAI avidity in this particular tumor, FDG. What are you sort of thinking about in this kind of case?
Yeah, so I mean, typically I'm thinking, these smaller follicular thyroid carcinomas are more typically radioactive iodine avid. She's not that, she's 42 years old. She's sort of slightly younger on the overall spectrum. I'd be expecting it to be radioactive iodine avid. So, I'd be really interested in this history to know, one, what the thyroglobulin levels were, that they didn't respond, and how high were they, and what was that change. But also I'd be really interested to know what the post-therapy scans looked like. Because if there was an elevated thyroglobulin, it'd be good to see if there was an iodine avid lesion somewhere, and a bit more detail about that, I think would be helpful.
David, let me follow up on that. We talk a lot about what's REI refractory. I mean, the question, how do you define what's REI responsive? I mean, I think you sort of mentioned you want to see the post-therapy scans. How do you know when radioactive iodine is really working that would make us want to keep giving a dose versus not?
Yeah, good question. I think it really depends on the disease and where it is and what you're treating. And so, is it sort of nodal disease, in which case often we're more typically following up with surgery if we identify that. So really this is more in the setting of more distant metastatic disease, particularly in the lungs, that is very iodine avid. And so that might be followed on a CT scan. And I think you're really wanting to see, structural response as well as thyroglobulin response. We don't typically use, radioactive iodine scans for follow-up. We'll more treat with radioactive iodine. We'll use a high dose. We may use I124 PET in selected patients to determine dosimetry and whatnot, and if they are avid before we proceed. But our follow-up is very much based on structural assessment with CT and thyroglobulin.
Yeah, absolutely. And I would say as to how frequently do the follow-up, David, I would say it depends on what the magnitude of the thyroglobulin, how high, that would tell me where to go look, and the thyroglobulin doubling time, right? If your thyroglobulin is biochemical incomplete and been stable for 3 years, I'm not going to be doing a whole bunch of imaging. So where did we go from here? Dr. Toro Tobon?
So this patient actually did phenomenally well until 10 years after initial diagnosis. No issues for the first 10 years, but after 10 years, thyroglobulin started going up, and it went up to 43.7 with a suppressed DSH. And as you can see, they went and tried to look for where is this coming from? And what you can see here, the whole body scan, is that there was a long lesion that was avid.
So I would say not an unusual time course, right? So whether we're dealing with well-differentiated follicular thyroid cancer with vascular invasion or some of the non-high-grade oncocytics with vascular invasion, they'll often look like they do okay for 5 years or 10 years. So to see a lung metastasis or a bone metastasis 10 years down the road in somebody that had 2 doses of radioactive iodine, not terribly surprised, right? So where do we go from there?
So a patient got radioactive iodine, 202 millicuries for the cumulative dose of 542, and the response was great. So you can see on the screen, thyroid globulin also decreased to 1.5 from the 43.7.
And what I'm seeing on the screen is kind of black shadows. What picked up on the screen here? Because I'm just seeing balance stuff.
So what we had on the pre, where do we have it? What we had on the pre, we had do I have the pointer?
Right, the lung lesion. Yep.
Yeah, the lung lesions on the pre. We had the lung lesions on the pre, and then we had the uptake on the lung lesions. On the post, those lung lesions had pretty much kind of disappeared. This is a post couple of months afterwards.
Yeah, so presumably that's a follow-up.
Yeah,
whole
that's
body
a month after.
It's like a 3 months follow-up.
Oh, okay. I got
Whole
you.
body
It's not
iodine scan.
it's not the immediate.
It's not
post-therapy.
immediate. It's not immediate. It's 3 months afterwards.
I got you.
Apologies.
Okay.
Yeah.
Okay, no problem. And do we know if anything structurally changed on that 3-month post, or we just lost RAI avidity?
So apparently the lesion completely disappeared.
Okay.
Yeah.
Is that TG stimulated or suppressed?
Suppressed.
Okay.
Okay, so we went from suppressed 43 down to 1.5. I'm always a little less impressed with response on thyroid globulin, but that's good. Structural changes is good and can be seen in this tumor, right? So this is legit. All right. So you've got me so far. So David, we're still REI responsive at this point.
Yep, that's correct. So
Okay, keep going.
Yeah.
So now we're in year 10, but we jump down to years 12 to 15. Patient did well for about 2 years, but we have again a rise in thyroid globulin from 7.4 to 148. We then went and did scans, lung lesion reappeared, and within a span of 3 months, it grew significantly. It doubled in size, and as you saw, thyroid globulin kept going up. So the patient was actually enrolled in a clinical trial because of the concern of the rapidly rising thyroid globulin and rapidly growing lesion. So the patient was enrolled in the selumetinib and placebo trial that was going on at the time, and also received radioactive iodine 148 millicuries for a cumulative dose of 690. And this was the result of the 3-month follow-up scan with the thyroid globulin of 39 decreased 80% from the previous one. And as you can see, the lesion had a significant structural reduction compared to the 3-month before.
This is a great case. Now, this lesion that came back in the lung, you think this is a different one that was treated or the same one that was treated?
So it's hard to tell. It was in a very similar location, but it's hard to tell. And the scans were a little on the older side,
Sure.
so it was very difficult to tell.
Okay. Frank, help me. I'm not used to selumetinib as single agent in this setting. Do you remember what was going on here?
Yeah, I mean, the whole idea here is, can we redifferentiate cancers to potentially give, more radioactive iodine? So, the interval's drawing shorter, the iodine therapy is starting not to work. So I'll be the naysayer here. I don't use it. I know some others don't. The data is off the map, on whether or not this particular strategy works. And some do. So, the argument you have to bring up is the MEK inhibitor that you give, selumetinib, is that what's doing the benefit? So do we have pre and post selumetinib scans to say, okay, there is the baseline here now following treatment with selumetinib, and then treatment with RAI, and then, scans afterwards. Oftentimes what happens is the med's given, and then RAI is given, and then you have this response. And so I don't know that we necessarily know in a lot of cases whether or not it really was the iodine providing the benefit or was the drug up front. So I think one has to take that into consideration. But nonetheless, in this particular case, whatever happened, the patient did, it looks like had benefit. The globulin dropped, the level, or the lesion looks like it's a little bit smaller.
Dr. Pattison, you guys got a pretty good experience in redifferentiation and I-124-PET. Take a couple minutes and sort of give me your sort of thoughts on where we are on that right now, David.
Yeah, certainly. Look, I think it's still emerging in terms of the data and what we're seeing for those clinical outcomes. I do take Francis's point about that some of these, on some of the trials, the Mary-O trial did show there was a change when they did look at that early, and then they also did see further, decline after. But I think that is a good point. But certainly, so we've got a trial called the iFirst study, and really, that's targeting either those patients with NRAS mutations with a MEK inhibitor, trametinib, and then those patients with BRAF mutations with dabrafenib and trametinib. It's also using thyroxine withdrawal as a mechanism of TSH stimulation in these patients. And there's a lot of imaging associated with it. And look, overall, we see excellent redifferentiation. I shouldn't speak about sort of particular details. I guess I should hold that back a little. But there is, and I've had other experience outside of the trial using this just in clinical experience. And just in clinical experience, I've had patients who've had a complete response, of pulmonary nodules, ongoing, with very good, redifferentiation. And sort of the thyroid cancer, when you're using I124 PET, you get a really good feel for, what would have just been a blush on a post-therapy scan to what is exceptionally intense. And so we do see, in a number of patients, that redifferentiation with an SUV max of, up to 1,000, which is just that's kind of what you see with normal thyroid tissue.
Yeah, perfect.
You do get some patients with very good responses, but the other problem is, and this is a key issue, I think, from an oncologic perspective, is that often the larger lesions that may be the resist measurable disease used in a trial by nature is more aggressive, it's more FDG avid, it's got a longer way to come back to restore that redifferentiation. And that is a real fundamental challenge about the oncologically significant disease and getting substantial response, because you may see, there's a lot of smaller lesions that may respond and be very iodine avid, but if those much larger lesions don't get the same redifferentiation, you're not necessarily getting that oncologic benefit you need. So, the jury's out and we'll see what the trials show.
That sounds great. We're starting to get up into pretty large cumulative doses here. Your group, like ours, we've used large cumulative doses like this in properly selected patients. We seldom do that anymore. Schlumberger put that 600 millicurie. It seldom works beyond that sort of level as one of the criteria. How are you starting to think about sort of the cumulative doses in a patient like this, JP?
So yes, this is actually part of what follows in regards to the case. So yes, you start getting concerned about bone marrow suppression, and when you're getting these levels of radioactive iodine, depending on the age of the patient, of course, issues of fertility and things like that, but mostly bone marrow suppression. So this was a concern for this patient. We were getting above 600 millicuries. Now, of course, you have to balance between disease control and bone marrow suppression, because there are alternatives for bone marrow suppression. So that is a thin balance here. I'm not sure if David, you want to show exactly what happened because of that.
Okay.
Yeah. So year 17, so 2 years after, thyroglobulin went up to 8,000. There was increased size in known pulmonary metastases, new right iliac bone, spine, multiple hepatic lesions. So the patient got stereotactic bone radiotherapy to right ilium, L5, and was started on lenvatinib. So unfortunately, this helped with thyroglobulin, came down from 8,000 to 1,000, but unfortunately, patient had severe toxicities, hypertension, stomatitis, diarrhea, weight loss, myalgias, fatigue. Medication was dose reduced first, but then it had to be halted because of grade 3-4 toxicities. And we had to think of different kind of approaches with him. And as JP was discussing, radioactive iodine had been an option in the past, but doses were high. So we went back to what was the genetics of this patient. And with a liver biopsy or with these new lesions, we actually got, 20 years ago, we didn't have tissue, but we went to the liver, got tissue, and obtained a new pathology and confirmed this was well-differentiated follicular thyroid cancer to original lesion, and got this new genetic testing. NRAS, PAK3CA, and TSH receptor activating mutation. So I guess the question here, or what we got, is how does this play into the consideration for us using radioactive iodine, and how, like, is this the reason why this patient has been such a good responder so far? And would this play a consideration into maybe keep using radioactive iodine despite the high doses that we have used so far? So
Great questions. Let's do stay there for me, David, because I think these are really key. Camilo, weigh in on this first, and then Dr. Pattison. We got about 4 minutes left, guys. Camilo?
I'm gonna be short. Food for thought, we don't know. I mean, genetic testing is so seldomly done. We see TSHR activated mutation in not oncologic disease, but toxicadenomas, things such as that, and they do capture radioactive iodine. If that changes anything, the short answer is I don't know. It might.
Yeah, but interesting. David?
Yeah, I mean, I guess I'd think, sodium iodide symport expression is so tightly regulated by TSH that that activating mutation, one would think and would hope that would drive that sodium iodide symport expression and then radioactive iodine uptake, just like as we do see also with those autonomous functioning thyroid nodules. In terms of consider treating again, I think this would be a perfect case for redifferentiation. We've kind of seen that already with the selumetinib, the NRAS mutation, and technically is already radioactive iodine refractory in a way. If you use the select, study criteria of over 600 millicuries, that's a very loose use of that criteria. But in terms of without access to redifferentiation, I think you certainly would. The main considerations are about cumulative toxicity. So this is both marrow, but also, salivary, lacrimal glands, how they've responded to previous doses, possible secondary malignancy, but I think it's perhaps less of a concern. And I think you'd be considering the timing of prior doses, how they responded, and again, what that toxicity was. And if the patient had responded well, I would treat them again. Yeah, I think it's a relative sort of consideration when you go to 600 millicurie. You don't just keep flogging people who aren't responding, but someone who's responding well, you would proceed. Yeah.
David, in 1 minute, finish out the case for me so we can see how this ended up.
Yeah, so the way for us to keep giving this patient radioactive iodine was to do autologous stem cell cryopreservation in case the patient were to develop any of the toxicities. So the patient got actually another dose, 295 millicurie for a cumulative dose of almost 1,000. And there was mixed responses. As you can see here, some lesions improved, some did not so well. And the patient got some transient pancytopenia, but did not require autologous stem cell transplantation. In the years 19 to 20, the patient developed symptomatic thyrotoxicosis with cachexia that persisted despite discontinuation of levothyroxine, required treatment with methimazole, had marked improvement, received 2 more doses of radioactive iodine. The total cumulative dose was 1,370 millicuries, mixed responses again. There was worsening in adnexal and skeletal lesions, but continued improvement, stable disease in pulmonary lesions. And she did develop new symptomatic metastatic skull lesion that required surgical management, and unfortunately passed away from complications associated with the surgical resection of that lesion.
Yeah, what a case. And certainly your first bullet point there would argue that the TSH receptor was doing something here, right? They get large enough volume disease, they can actually get thyrotoxicosis from their actual metastatic lesions, and these can be a challenge. I've had to block and replace them because trying to manage them on methimazole alone is really a challenge. So I think a very interesting case to come up with. All right, Pranati, show me the final slides here and we'll finish up. The panel, JP and team, thanks for wonderful cases. Great for us to think about and work through. The upcoming panel discussions are listed here that we have coming up on our sessions. And then one last reminder, Voices of Wisdom. Did I get it right this time? Because I always say this wrong. Next slide, Pranati. There we go. Perfect. Okay, perfect. That sounds great. Panelists, thanks for a wonderful discussion. You guys did a great job as always. We're right on the time. Thanks now.